To share my case, actually is the patient is 50 years old Thai male and presented left hip pain for 3 years. And past history, 20 years ago, he got a car accident and he got multiple close fracture and underwent a left total hip from that time. And physical examination seemed to get some limitation of the left hip joint and also leg length shortening about 4 centimeters with pain on motion. And he has no other comorbidities. And this is the X-ray we saw him at that time. It's a kind of ceramic and cemented fixation on the stem, but the cementless fixation on the acetabular side. And this is the open leg view. You see some limitation. And we did the CT scan for this patient, and you can see the big cavitary defect and also up and out also. And anyway, the posterior limb and anterior wall still intact. So when we evaluate with the CT and also the ESR CRP, we think that for the defect on the femoral side should be Papotsky 3A, because we expect that we're going to have at least 4 centimeters for scratch fit. And for the acetabular defect, we think that it should be 2Cs. And then our plan, we just very straightforward for the acetabular defect, 2C, just put in the bigger cup or jumbo cup. And the femoral stem is just easy, just try to get some long stem that get diaphyseal fixation. This is what we did. So it looked nice, but anyway, when I compare the size of the stem, it seemed to be a little bit smaller than I expected. And for the cup, I would say it's good in terms of abduction, but anteversion is a little bit less. We can correct the leg length back to about 2 centimeters, but anyway, it's still shorter. This is the ETO, and that time we found that during the trial of the component, also the reamer, we found that it's quite fit and it should be very decent for the size of the stem. And here's the post-op film. Even though it looked like not fill the canal, but actually you can see some tiny cortical bone inside the canal, you see there. But when we follow the patient 7 months later, you can see the stem sunk down, because this is a long cylindrical stem, even though it's modular revision stem. And then we found that the patient seemed to get a limping gait. And when we follow the patient longer, because the patients always say that he's still doing well. But when we found that the stem sunk down too much, so we think that this is something error, that we thought that 3A femur is not good for cylindrical stem for this scenario, because we might choose the longer one. So we asked the patient to come back for revision of the stem. And this time we put in again cylindrical stem, because we don't have fruit taper. And this time you can see that the size of the stem is pretty much is about 4.5 millimeters larger than the previous one, and seem to be good. And we use the trochanteric slide. And again, when we follow the patient, it heals nicely on the trochanteric slides. And then we follow the patient longer. The patient did well. And you see, this is about close to 2 years. And then the patient lost follow-up for another 4 years. And then he presented with sleeping, falling down, and pain on the left hip. And the pain is so severe that he could not walk. But when we see the X-ray, it looked quite worse than what he said, just a simple fall, because you can see the cup migrate and screw get broken, as you see here. So now I would say that the bone defect, but this time we didn't do the CT scan, but I would say at least it should be 3A for the Papotsky classification. At this juncture, you can see that if you look at this area is actually in that time, we put in the jumbo cup, but the size of the cup is not matched well matched to the ML dimension, but it will match in the AP dimension. So this is part of hydroxyapatite. And this time, when we evaluate the patient, we know that the patient don't have a superior and the posterior bone support. So this is why, again, we work up for the infection. And then we need to go to the tubercular metal. So we put in the TM space and also the column to support the posterior superior and the TM cup. And this time we also do the thoracic size and seem to be good in terms of post-op film, and we can follow the patient 1 month, and this is 2 months. And the stem cells again look well, and we follow the patient longer and longer. So now 2 years post-op, he is still doing well, and this is the way he walks. So the lesson learned from my case, first, if you think that the defect on the femur is 3A, sometimes even though you use the cylindrical stem diaphyseal fixation, make sure that it's not a 3-point fixation. It should be circumferential fit, and you must test. If you find that the diameter of the canal is not big enough, so the diameter of the stem is not big enough, so you must be careful that it can come loose. And then for acetabular side, we found that 5 years later, it can come with the cup loosening. So I believe that at the beginning, it do not clear the bone ingrowth. So this is why currently when I use the cup, I would go to the more porous material. This is lesson learned for me. Thank you.
Okay, excellent case. Any of the panelists has any comments? Okay.